we'll just give it a few minutes for people to come in.
Yeah, that's fine. Just let me know when you want me to start. Okay, so I'm hoping that people are ready to make a start. Essentially, my name is Chloe. I'm a CT2 in psychiatry in the West Midlands. And the Mind the Bleep team suggested maybe a webinar on applying to psychiatry and what it's like being a core trainee in psychiatry as well. So I have put my email on the first slide and on the last slide. So if you think of any questions and you don't get a chance to ask them or anything, just feel free to send me an email and we can kind of discuss them. If there's any questions during the talk, like I don't have access to the chat or anything, so maybe just pop them in and then we can look at all the questions at the end. So there's a couple of different kind of myths of psychiatry, I would say. And these are things that I heard a lot of before I actually went into psychiatry. And some of them I still hear even when I'm in it. So there's this kind of thought that the patients are dangerous because you hear about psychiatric patients who might end up being involved in crime, or you might hear about attacks on psychiatric wards. Some people feel that psychiatric patients don't get better. So it's quite important to remember that most branches of medicine do have chronic illnesses within them, and psychiatry is no different to that. So there are patients who have chronic illnesses, but there are also patients who you can help to get better and they may never see a mental health professional again. Sometimes people feel like psychiatrists only deal with medications. So that's something you hear more when you're actually working in psychiatry, because we have a very big MDT and they have other roles as well. But it's important to remember that as a psychiatrist, you can sit anywhere on the spectrum of the biopsychosocial model and you can adapt your approach depending on the patient that's in front of you. And then there's the opposite thing where people outside of psychiatry feel that there's no medicine involved in it. And that's one of the big things that I was worried about when I was applying, because I didn't want to lose my medical knowledge, because I feel like you go to medical school and you work so hard to get your degree, and then you end up leaving some of that behind. So I think generally when you start working in psychiatry, you realize that there is definitely medicine within it. And even though you're treating the mental illness as the priority, and that's what you're kind of specializing in, there's still definitely a lot of medicine, and you still need to have that medical background. And then some people feel that nothing really happens in psychiatry. So they might have a placement at med school, and actually they go to a psychiatric clinic and none of the patients turn up, or the patients don't want to speak to them. So it feels like nothing actually happens. But psychiatry is a very broad specialty. So there are some roles in psychiatry where I would say things are more slow paced. So it could be like a community clinic, or it could be a rehab ward, and things are very more chronic and slow there. But you can also be at the opposite end of psychiatry, where you're in an acute environment. So you might be in a liaison service, or you might be working on an acute ward, and you're managing people who are very unwell, and their situations are very acute. So there's lots of things happening then. I guess the way that I would kind of describe psychiatry is you're combining your medical knowledge with your scientific background and your interpersonal skills. So you're using your background of physical health, and you're combining that with the expertise that you're gaining in mental health to be able to create real change in people's lives. So what I'll do is I'll tell you a little bit about my experience of core training in psychiatry and the application process, and then I've left quite a lot of time for questions, because that's usually something that's quite helpful, I think, for these things. So this is my current kind of work schedule. So on a Monday morning, I see my psychotherapy patient. So that's part of core training, is you have to see at least 2 psychotherapy cases. So you do a long case and a short case. So I'm kind of 2/3 of the way through doing my long case of psychotherapy, which means that I meet with my patient, who I selected for the therapy, every week, and we meet for 50 minutes, and we do psychodynamic as the modality. So essentially we talk about anything that she wants to talk about, and then I do the kind of stereotypical Freudian thing of trying to make connections of what she's talking about, and from that she gains a deeper understanding of her kind of issues in life. So her formal diagnosis is PTSD and depression, but actually throughout the therapy we've spoken about a lot of other things aside from her mental illness. And what's really nice is, even though the session is only 50 minutes, I actually get the whole morning dedicated to that. So I have time to go and set up the room, time to actually sit with the patient and do the therapy. And then I have time to sit and document and reflect on it, because after you have seen the patient, you need time to think about what's happened in the session and try and make some of those interpretations and see if there's any themes that are coming up throughout the sessions. Then in the afternoon, I go to my ward. So I'm currently on a learning disability post. So I go to Brooklands Hospital in Birmingham, and I just cover if there's any jobs that need doing. So for example, things that I tend to deal with are the patient's physical health. So if there's any concerns about their physical health, I might be asked to go and see someone. I might be asked to do some tribunals or tribunal reports. Might be asked to attend some formulation meetings. And then Tuesday is a very similar thing. So Tuesday, I'm dedicated to the ward all day to deal with any of those tasks. If we have like an MDT to discuss somebody, or if we have a treatment review meeting as well. So there's lots of different things, and there's time to kind of work on your portfolio, and make sure that you're keeping up with assessments and reflections. And if there's any exams coming up, like I sat with my second paper during this job, so I used some of that time to do some revision as well. So Wednesdays, because I'm on a split post, Wednesday is my community day. So Wednesday morning, we have an MDT, which is scheduled for the whole morning, but usually finishes after an hour to an hour and a half. So I usually get some time just to catch up on admin for my community patients. And then I run a clinic in the afternoon. Generally, the clinics vary depending on what post you're in. So at the moment, I would say I don't see more than like 5 or 6 patients in an afternoon. And things are a bit different at the moment because it's coronavirus. So there's a lot more like Microsoft Teams meetings or phone calls, but I imagine that's similar across lots of specialties. Then Thursdays, we have the MRC Psych Deanery teaching. So this is put on by the West Midlands Deanery, and it's all of Thursday morning, and it's basically a couple of hours where they'll teach you about topics that link directly to the membership exams. So it's really helpful to give you some more prep for if you're planning on sitting them. And then in the afternoon, I just have a session to cover the wards or catch up on any admin that I might have to do that I haven't finished from Wednesday. And then Fridays are a ward round in the morning. And then in the afternoon, I have supervision with my clinical supervisor. So every psych trainee should have an hour of supervision each week. And that's where they sit down with their supervisor and talk about anything that they want to talk about, really. So I usually make sure if I need any assessments for my portfolio, we get them done in that time. I might talk about any particularly difficult interactions I've had with members of the MDT or any patients who were more challenging. I might talk about, like, if I don't know what to do for a patient's plan, like if I saw somebody in clinic and I wasn't sure where to go next with them, I might discuss that. And then I'll also have supervision with the psychotherapy tutor. So that's where I discuss the content of the session that I had on the Monday, and I speak to them about the different themes that are coming up and the different reactions. And you have supervision with the tutor, but you also have other core trainees there, and they kind of give you ideas about what's happening with the patient, and they help guide you through the therapy. And then after that, we have our balance group, which some people might have heard of already. So it's a reflective practice group where you would normally talk about difficult interactions with patients or with staff. And generally you can talk, it's kind of like a debrief situation. You can talk about anything that you want to, but most of the traditional balance groups, you discuss a case. So if there was a patient who I'd seen and I'd found that that patient made me particularly angry, I might discuss that case for 20 minutes, like present it. And then the balance group would talk about the case for 20 minutes without my involvement. So I would just be observing the group. And then I would be invited back in to rejoin the discussion and see what other things came out of it. Because often if you have a strong reaction to a patient, it's to do with some underlying like psychodynamic interaction that's happening between the two of you. So it can be quite helpful to bring cases that are more stressful there. Okay, so with the application, I imagine quite a lot of the questions are around portfolio. So this is just the way that I kind of did it. So I tried to gather things when I was at medical school. I tried to gather really generic things. I thought that I wanted to do psychiatry, but I wanted to keep my options open. So I tried to make sure that I did a lot to do with medical education. I did attend like a psychiatry summer school as well. But generally, I just tried to build things up slowly over the years, especially because I feel like at medical school, the it's already quite a big ask to have somebody dedicate that much time and also to work so intensely towards their degree, that you can't be expected to do all of these massive achievements. So I would say try and build slowly over the years. And if you know that you're interested in a particular specialty, then it may be helpful to look through the application at the time to see if there are any points that you can only get when you're an undergraduate. Because once you have qualified, there'll be some opportunities that are gone. So an example is like intercalating. So you might be undecided about whether you want to intercalate if you have that option with your degree. And it may be that you get a few points for doing that when you come to applications, but you wouldn't know unless you checked. And once obviously you've graduated, you don't have that opportunity anymore. Psychiatry do publish a person specification, and that is what I based my portfolio on. So it had different sections, and that's how I structured the contents. And I kind of went through and made sure that I had something for all of those sections to try and score as many points as I could. And when I was in foundation training, and I also had an F3 job as a clinical teaching fellow as well, I tried to make sure that I did lots of like conferences and courses to try and up my points, because I was quite conscious of the fact that I hadn't done that much when I was at medical school. The Royal College of Psychiatrists have some really good bursaries for their courses and conferences, but they also have loads of prizes. And a lot of the prizes are for medical students, and some of them include medical students and foundation doctors. So it's actually quite a small group of people going for the prize compared to prizes that are open to all grades of psychiatry and medical school. So I would say definitely check those out. And there's lots of different faculties on the website, and a lot of them offer a prize each. So there's lots of different opportunities to try and get a prize on your CV, which would count for a couple of points. So with the application process, so I'm talking more about when I applied, because that was my experience of it. And things do change over the years. And I think coronavirus has had an impact on the interview process. So generally with psychiatry, it's similar to the other specialties in that you apply on Oriel. And once you've applied on Oriel, you'll get longlisted. And because historically psychiatry has been harder to fill, most people, when I was applying, made it to the long listing stage. So they were able to go to the MSRA. So everyone sits the MSRA, and if you apply around like October time, you normally sit the exam around December, January time. And there's lots of online resources that you can use to help prepare you for the exams. You can get like question banks that you can practice to try and help with your score. Once you have sat that, at the time that I was applying, they said that the top 10% of psychiatry applicants, so the people who had the highest scores, were able to bypass the interview process. And I think that is still the case at the moment, but I wouldn't rely on that, because as psychiatry is becoming more popular, they may take that option away. But at the moment, I think it still stands that the top 10% get to bypass the interview, and they get their top choice job as well. So if you do go to interview, so you get shortlisted, you are invited to interview, which used to be, at least when I did it, it wasn't that long ago, it's only a few years ago, but they interviewed in 2 centres, one in Manchester and one in Glasgow. So I attended the interview in Manchester, and it had two stations. One of them was a clinical scenario and one of them was about the portfolio. So in the clinical scenario, there's generally more common histories that tend to come up. So the one that I was told comes up very often is you're an FY2 and a patient has turned up to the pre-op assessment, like the day of their surgery, and they've turned up and they're clearly intoxicated, and the anaesthetist has said that they can't have the surgery because they are like too intoxicated with alcohol, and the anaesthetist has very kindly left the job to you to go and tell them that their surgery can't go ahead. So the station is all around you communicating to the patient that they can't have their surgery. The one that I had was a 15-year-old boy had been brought to A&E because he'd taken an overdose due to bullying from people at school. So it was around taking a bit of a history and getting some risk assessment completed for him. And then we were asked to kind of sit back, talk about some of the main points of the case, but also reflect on how we felt the case went and how the interaction went. And then the portfolio station is you sit with a panel of, I had two people, and you are just asked questions. Really, it's all about how you can show you meet the person's specification and how you can show that you are going to not drop out of the psychiatry program and how you're dedicated to the specialty. I have my portfolio here, which I haven't actually looked at since I applied, but this gives you an idea of the sort of stuff that I had in, and I'm happy, like, if people have any questions about what's in it, I'm happy to go through that after. I would say generally, I think I got 39 out of 40 on the portfolio station, to give you an idea. I think I dropped 1 point because one of the sections is around volunteering, and I hadn't done any volunteering for quite a few years when I applied to psychiatry. And then once you've done your interview, you then have your MSRA score and your interview score combined, and that gives your overall ranking. And then it's similar to any other specialty where you've ranked your posts, and depending on where you rank will decide what post you get. So this is the kind of psychiatry training pathway. I think what I didn't realize until I started like working in psychiatry was how broad psychiatry actually is. So you have your degree and your foundation training, and then you do core training, and in core training you have certain jobs that you have to do, like the trust has to provide you with certain training rotations. So you have to do 1 year of general adult, which is normally split into 6 months inpatient and 6 months outpatient. And then you have to do a developmental post, which is either a learning disability post or a CAMS post, and that's 6 months as well. And then you have to do an older person's mental health post, and that again is 6 months. And then you're supposed to have 2 posts, which are called like specialties posts. So the idea is that these posts are supposed to give you an experience of other subspecialties of psychiatry that you may not have really known much about or experienced much of up to that point. And it's supposed to try and help you decide what higher training pathway you want to apply to. So, for example, you might have placements in liaison psychiatry, neuropsychiatry, perinatal psychiatry, psychotherapy, forensics. There's kind of these other areas which you kind of have heard of, but you haven't really, like, unlikely to have experienced that much of. So the higher training, it says like 3 years in the picture, but that comes with a little caveat of 3 years is the shortest. So if you wanted to do general adult, for example, you could do general adult higher training in 3 years and you could be a consultant. So it would only take you 6 years to do core training and higher training. If you wanted to do something different, so if you wanted to do medical psychotherapy, for example, that training program is a bit longer. So I think that one is more like 4 years. And the good thing about psychiatry is you can really mix and match. So if you really like psychotherapy, but you also really like general adult, you can do both of those things and dual train for your higher training, which again would add on more time. So you'd probably be looking more at like 5 years for your higher training. But you can combine lots of different specialties. So you can combine LD and forensic, combine general adult and older adult. You can do general adult and then you can get accreditations in addiction psychiatry or liaison psychiatry or perinatal. There's all these kind of, psychiatry has so many broad things in higher training. Like there's lots of different subspecialties that you can kind of look at. So I would say with psychiatry, like it's, I think some people don't consider it because they feel like it's not for them. But because psychiatry is such a broad specialty, it's really worth having a look at what there is, because some of the subspecialties are very biological. So something like neuropsychiatry, for example, is very biological, but some of them are very psychological, like medical psychotherapy, that you wouldn't really deal with medications or physical health at all. So it's really broad depending on what type of clinician you like being. So why choose psychiatry? Well, these are a couple of things that I kind of thought of. So the good opportunities in psychiatry. So you have time to speak to your patients. It's a specialty where generally you don't feel rushed when you're with people. I think because you're managing people's mental health and emotions, services kind of recognize that you need more time with those people. So for example, like if you were seeing somebody for the first time, you would be expected to spend an hour with that person, to go through their psychiatric history and their mental state and their risk. And I think sometimes the experiences at medical school don't really reflect what working in psychiatry is like, because they have to assess your skills in psychiatry, and they choose to do it in an OSCE where you might get 10 or 15 minutes to do those things, whereas in actual clinical practice you get a lot more time. You're part of a really wide MDT, which is nice because you can learn from other specialties, but also you have lots of support. So you're never really expected to make a decision about somebody's life by yourself, like you would normally consult with the MDT, which can be quite helpful, because one of the challenges is managing risk in psychiatry. And if you have an MDT who are good and they're supportive, you're able to manage that risk more easily because you're sharing and you're discussing that decision as a group. So as I already mentioned, it is a very varied role. I feel like even my kind of day-to-day work is quite varied. But there's lots of subspecialties as well, which suits lots of different kind of personalities and from what people want to get out of work. I'd say it's a very stimulating specialty. Like, I remember when I was a foundation doctor, I would see, like, I would be clerking people, and it was very much like X plus Y equals Z, and you would follow that same pattern for every person. And even though psychiatry does have some patterns, so for example, somebody comes in with psychosis and you're very likely to give them an antipsychotic, and they should really improve with that. There's also more complex things where you do have to think more, and it kind of gives you more stimulation in your everyday work. I would say the stigma around mental illness has got better over the years, but when you're actually working in the specialty, it gives you a chance to really try and tackle that from kind of working within it. And there's lots of kind of people who work in mental health who also work to try and reduce stigma around it. And that, I would say, there is a good work-life balance. Maybe not as good as if you didn't work in the medical profession, but it's better in my experience than some of the other specialties that I worked in when I was a foundation doctor. The advice that I always give to people is, when you are thinking about a specialty, really see how the consultants are, because you will be doing what they're doing for a very long time. And if they are, you know, as a consultant, if they're regularly coming in to do like ward rounds on a Saturday, you have to think, like, will I still want to do that when I'm 50 or 60? Because realistically, you probably will still be working at that age. Challenges wise, there may be some parts of your medical knowledge that you don't use as much, but I would just kind of advise a bit of caution when thinking that, because there's lots of specialties where you wouldn't use certain parts of your medical knowledge. Something like A&E is probably great, or GP is great, because you see lots of different things. So you need to really keep on top of lots of your knowledge. But if you are going to be like a really specialist surgeon, or you choose like a certain medical specialty, then there may be areas of your medical knowledge that you don't use as much, just as you would if you decided to specialize in psychiatry. It can be emotionally challenging. I wouldn't say draining is the right word. I think challenging is probably the best way to describe it. I would say there are times where you see people and they are in distress, or they're having a really difficult time, and you have to be able to be okay with that, and you have to be able to you know, potentially see somebody who's telling you about how they really want to kill themselves, and then you have to be able to go and see the next person, whatever their kind of presenting problem may be. But I think the positive thing is that everyone acknowledges that psychiatry can be emotionally challenging. So you have the supervision with your consultant, you have the supervision with the psychotherapy tutor, you have the Ballant group, and the core trainees. Like, as a whole, I would say that all of the experiences that I've had, everyone has been very supportive of one another, because they know what it's like to be a trainee in psychiatry, and they know that you can see cases that are more kind of emotionally difficult. What I found was, I see people who are more emotionally distressed in psychiatry, but I actually feel better with it because I have more support than when I worked in other specialties, and I would see people in distress, or I would see people dying, and there wouldn't be anyone to talk to about it, and you would have to just kind of debrief with your housemates at the end of the day. because there wasn't really any other outlet for it. So that is pretty much all of the slides, because I wanted to make sure that we had lots of time for questions. I've put up a couple of links, like the Royal College did quite a big campaign to try and get people to know more information about what it's like to work in psychiatry. So I've put a link to their Choose Psychiatry campaign. I've put a link to the person specification and to a YouTube clip, which is part of the Choose Psychiatry campaign as well. Yeah, I'm just trying to think if there's anything else. If you want to ask questions now, that's fine. Or if you want to email me, that's also fine.
Thanks so much for that, Chloe. That was really informative, particularly like the bit at the beginning about the myths of psychiatry, and it was good also to see what you guys do in a day. I feel like that would be really helpful for people thinking of applying. I think what we'll do now, just while we wait and see if anyone wants to pop questions in the chat, is I'll just ask you a few questions and then we can see if any more roll in, if that's all right.
Yeah.
Okay, so why do you think you picked this specialty, if you could think of a reason?
Yes, the story of how I picked psychiatry is quite funny, really. So I was at secondary school. I found human behavior really interesting. So I thought, why do people act certain ways? Like, what's motivating their behavior? And we did a careers questionnaire. And out of my top 10 jobs, I think 6 of them were branches of psychiatry. I think the top one was a medical psychotherapist, and there was another one was like clinical psychology as well. So I went to college and I did psychology A level, which I really enjoyed. And I thought about being a clinical psychologist. And then I saw how difficult it was to become a clinical psychologist. And I thought, I'll go to medical school and see if I like other specialties as well as psychiatry. And it was always, everything was being compared to psychiatry for me. And it was always that I preferred psychiatry. And then I really enjoyed my foundation jobs. Like, I loved my surgical job. I loved my medical job. I did a psychiatry job as well in foundation training. And I also did a GP job, which I thought would be the strong contender for the other competing option. But actually, I hated my GP job. And I found that I didn't have enough time to speak to patients at all. So I did my F3 as the teaching fellow, and that was in psychiatry. So I worked on a psych unit for a year as well. And then after doing that, I was really sure that that's what I wanted to do.
Okay, so it was in the cards for me right early on then.
Yeah, I think I liked human behavior. And then as I got older, I wanted to find a way to use science and talking to help people.
Yeah,
kind of like fits with medicine.
Yeah. Okay. And I know you did touch on it, obviously, about the challenges, but I suppose, is there anything personally you found quite challenging as you've been training in it and as you've been going through this whole process applying? Is there anything in particular that you've found has stood out as particularly challenging?
There will be people who remind you of yourself, or they remind you of somebody you know, and that can be difficult because you might find yourself acting in a certain way and you don't realize that why you're doing it. But as you become more experienced in psychiatry, you actually become more understanding of deeper psychological processes. So for example, like you might meet somebody that you really don't like, and you don't know why, but you just don't like them, and they're just not your sort of person, and you don't want anything to do with them. And or you might be, you know, like you meet a patient who really annoys you, and before you worked in psychiatry, you might be like, oh, I really hate this patient, but I feel bad about that, or whatever. And then when you work in psychiatry, you start talking about those things, and you start to realize that it's okay to feel that way about a patient. And the feelings that you have are because you are human and you're making a human connection with that patient. And when you start to talk about it and undo it, you realize that you might not like that person because of a psychodynamic process that's happening, or because they remind you of somebody who maybe wasn't very like pleasant to you in the past or something. But it's only like as you become more experienced in psychiatry that you start to realize those things.
Yeah, that's really interesting, actually. You're basically analysing yourself at the same time.
Yeah.
Okay. And what have you found particularly enjoyable as you've been going through? Is there anything that sort of really made you think, wow, I've definitely chose the right specialty, you know, I'm really enjoying this?
Yeah, I think like every day.
Really?
Yeah, it's good. I mean, for me, the fact that I don't mind going to a set of night shifts makes me feel like I made the right choice. So, you know, like I didn't really talk much about on-calls, because I think on-calls really vary depending where you are. But where I work at the moment, we work an average of 1 in 3 weekends, and we do at least one long day a week. But it doesn't feel like work. Like it's just enjoyable to actually see the patients and to talk to them, and to have those really challenging interactions with people. You know, like I really like going to see people who have EUPD because they're so challenging on like a psychodynamic level that I find it really interesting. But I know if you say EUPD to somebody in A&E, they would probably start crying.
That's really good, obviously, that you've felt that way. I'm sure you're going to persuade a lot of people to feel the same. So obviously, because we've got a little bit of time, I wondered if you might be able to just give a couple of examples of the things that were in your portfolio. I know you said that you didn't really have time, but just a couple of examples might be good for people to hear.
Yeah.
If that's all right.
Let's have a look what I've got. So obviously it's quite common in your portfolio to start off with like your degree and stuff like that. So I put all of those basic things in. And then I completed a postgraduate certificate in medical education in my F3. So that's in there. That's quite handy as well, because if you choose your jobs carefully, you can get that funded. So I had that 100% funded, which was good. Yeah, then let's have a look what other things I put in. So I put in a little bit about reflection. So I tried to put in some of my more interesting reflections. I put in, you know, like journal clubs that had been quite interesting, or, you know, like, because obviously I was working in psychiatry at this point, I put in a tribunal report that I'd written and received really good feedback for, and some like assessments that had received really good feedback. Just see what other things have I put in.
So is it sort of just kind of up to you what you put in there, and what sort of demonstrates that you're, you know, really interested in the specialty and have been doing work in the specialty?
Yeah, and I think as well, like I based it all on that person's specification. So when you look at the contents page, it's like reflective practice courses, clinical governance, poster presentations, teaching, activities outside medicine, like they're all in different headings. I went on a couple of courses. So I went on some courses that weren't linked to psychiatry at all. And I went on some courses that were linked to psychiatry, and I got points for both of them.
Okay.
Yeah, and like poster presentations and publications and stuff like that. Like I didn't really have that many publications. Well, I don't think I had any publications when I applied. But I tried to choose like audits or quips or poster presentations that link to psychiatry. So even though like I did a couple of quips in foundation, I chose to put in like the ones that were linked to psychiatry, because you are unlikely to be able to put everything in your portfolio.
And you said you started working on this around medical school time, you said?
Yeah, so at medical school I did kind of like a little bit of mentoring. So I helped students apply to medical school. So I helped people with their personal statements. And I helped with a couple of lectures for like revision societies. And I did go to some like psychiatry society events, but I didn't actually put those in my portfolio. But that's all I really did at medical school. I didn't really do much. And then, and I went to that one summer school as well. Sorry, I went to a psychiatry summer school too.
Okay.
But then after that, it was just in foundation. I tried to make my quips link to mental health. And then when I did my F3, that's when I did like the PG cert, and I went to more courses and stuff like that.
Okay. Great. Well, we have got a question now. Someone has just wrote in and said, what would be the best way to get a taster of whether working in psychiatry is for me? Due to the pandemic, I wasn't able to have any clinical experience during my psych rotation.
Yeah, I think this is a really good point, because working in psychiatry is very different to being on placement, or like even being on a taster week is different to actually working, because in a lot of specialties, you're used to the majority of patients really playing that patient role. So, like doctor turns up and doctor says, okay, I'm going to take your history, and the patient answers the questions, and then you say, okay, I'm going to examine, and then the patient lets you do what you need to do. Whereas in psychiatry, some of the patients have lost that filter, or they've lost the like mental ability to play that patient role, if that makes sense. So you might turn up on your psych placement and go to the wards and say, oh, is there a patient that I can talk to? And you get told to F off by every patient that you try and speak to. But when you're the doctor in psychiatry, it's very different, because now the patients have to speak to you. When you're a student, it's like, is it okay if I speak to you? Whereas when you're the doctor, somebody who would tell you to F off is probably there against their will, which means that they have legal framework in place, and they know that they have to speak to the doctor if they're going to stand a chance of getting out of hospital. So when you are a medic in psychiatry, you will gain a lot more experience of what it's actually like. So my advice would be to get a foundation rotation that has psychiatry in it, because only after you've really worked in it as a junior doctor will you have enough of a taste to really know if it's for you or not.
Okay. Great. Well, I think for now that's all the questions, it seems like. Let me just check for sure. Yeah, I don't think there's any more at the moment. So I think Chloe said that it would be okay if you guys emailed her if there was anything else that you sort of forget to ask in the moment. And don't forget also to fill in your feedback. Use the QR code on the screen and you guys will get a certificate of attendance, and you can, you know, add that to your portfolio if psychiatry is something you're interested in. And I think that's everything, Chloe. So thank you so much. It was a really interesting, really informative talk, and I think hopefully the people who are watching have gained a lot from it.
Yeah, hopefully they all decide they want to be psychiatrists. Yeah, I would say psychiatry is becoming more popular. Like, I think I looked up the ratio and it was 2.99, which is a lot higher than when I was at med school. But we need good psychiatrists. Like, we need people who are interested and passionate about mental health and helping people to have, you know, happy lives. And yeah, I think definitely we need people like that to apply.
It's an ever expanding specialty as well at the moment, isn't it? So it's, you know, the need just gets greater if anything. But what was that? You said the competitive ratio was 2.9 now?
Yeah, it's 2.99. So it has gone up, which is why, like, the thing with the bypass and stuff like that might change in the following years if psychiatry continues to become more popular.
Okay, yeah, so that's interesting to know as well, actually.
Yeah.
Okay, so we've put on the feedback form for everyone. So I think we'll leave it there. So thanks so much, Chloe.
Okay, thanks very much.
Thank you.